Okay, well, that's just a little something about me. I'm a very strange psychiatrist because I've spent most of my working life working in other people's environments. I really prefer that. And I've never really got hospitals out of my system. So this is where we are today. I'm just going to do a very brief introduction before Morwenna takes over and gives you something a bit more approaching everyday life. So, but there's one thing I need to say to you in the introduction, and that is that I'm going to give you a certain amount of theory and research, because what we've found in this pandemic is all the things we thought we knew about major incidents, emergencies, disasters, have all applied without exception in the pandemic. It's absolutely extraordinary. It shocked me, I have to say. Just a few definitions to start off with. Oh no, here we go. I was sent this slide a couple of months ago, and I was asking people, what is the second wave like? And I got that. So I don't know how many of you would agree that that is right. That is what it's been like in the second wave. People have told me that it's nothing like the first wave. And I think we can explain some of that too. So that some of that will come up. And half of helping people is to help them orientate themselves and understand why they may have experienced certain things. But here come the definitions. So I use the term psychosocial to refer to emotional, thinking, social and physical experience of people in their own contexts, because it's so much broader than psychological. And as we all learn, so many of the things that we're going to be talking about are actually social processes, both the things that cause problems and the things that resolve them. So psychosocial care is that care that which is not a psychiatric care by any manner of means, to assist people to cope with the distress that so many people experience when they're at work. None of that is unusual. It's to be anticipated, but people may need support with that. And when I use the term mental health care, we are referring to these more traditional biomedical, psychological interventions for people with diagnosed disorders. We're not going to say a great deal about that tonight. We're going to talk much more about the messy psychosocial end of things. So over to Mo. Mo is going to take you into this territory in quite a graphic way. Mo, are you ready to go?
I am, yeah, ready. Could you move me on to my next slide, please, Richard? Thank you. So I've always wanted to be a nurse, I think, ever since I was a little girl. I think it's all I ever really wanted to do. I've been working in intensive care for the past 12 years. I work in Southmead in Bristol, which is one of the largest intensive care units in the country. I have a team of 250 nurses, but when I say team, I think what I probably really mean is my gang, my work family. I have always loved ICU. It is always what I wanted to do, and I can't really explain precisely why, but I think it's where I feel like I belong. But there was a point last year where I questioned this for the first time ever. Was this really the long-term career that I had dreamt of since my childhood? And it really, really scared me and saddened me that these feelings that I was experiencing, having never experienced them before. Why was it that I was experiencing this? Because I'm no stranger to trauma. Having done 12 years in ICU, I've seen multiple traumatic events, and I thrive at working under pressure. So what is it that's been different about this year? I think for me, this year has been more about sustained high intensity rather than the pandemic itself. So what's it been like for me, us, my team, during high intensity working? And firstly, where does high intensity working even start? If you watch the evening news, you could be forgiven for thinking that the past 12 months have been about the numbers and the statistics that tell the story. But that's not how it's felt for me or my colleagues and the rest of my team at the sharp end of this pandemic. Because if you watch the news, as we all did, telling us what was coming, showing us pictures of hospitals in desperate situations elsewhere in the world, and realizing that this virus was heading our way, then the term anticipatory anxiety doesn't really speak loud enough about the tensions we felt as we prepared for the inevitable. Converting single size rooms to accommodate 2 patients so that we were essentially doubling our capacity, scraping together equipment to kit out those bed spaces, practicing donning and doffing time and time again, fearful that if we let any part of us exposed, that actually we transfer COVID to others. Having a crash course in an anaesthetic machine, I never thought that would ever happen in my career, and the stress and the chaos that that produced. Pulling out key leaders out of ICU to go and set up a Nightingale hospital 4 miles down the road. And then the mega team, who were absolutely wonderful, staff drafted in from other areas to help us out, but who came with their own anxieties, and there we were worried that we wouldn't ever be able to support them in the way that they needed. And then there was always that talk, wasn't there, of who would and who wouldn't get a bed in ICU. And the realization that relatives wouldn't be there at the end of life for their loved ones. So I think for us, moral injury snuck in a long time before we even experienced it firsthand. I could go on, I think the list is fairly endless, and I'm sure that you all will have examples of your own. But it wasn't always like this. There were times where I genuinely felt excited. This is what, after all, we are trained to do, look after the critically unwell. And I remember the time that we had the first phone call from our Emeritus team telling us that the first intubated COVID patient was coming up from my ED, and that rush of adrenaline that we all got, and the teamwork and camaraderie amongst us was absolutely at its best. But I'm not sure how long those feelings really lasted for. Next slide, please, Richard. In June and July of last year, when those COVID cases started to drop off slightly, and we were led to believe that there was this lull between the 2 waves, I took the opportunity to stop and to catch up with my team. We hadn't really had any time to have such conversations during the high intensity phase. The conversation followed a format, a definite plan, which was based loosely on an IHI conversation and action guide that they released to support staff wellbeing during this pandemic. It basically focused on getting things back together again. We checked to see if everybody was okay, obviously, but it was all about coming back together again as a team. And it's fair to say that actually there were lots of members of my team that felt quite a strong impulse to have conversations like this. We actually recorded some of the conversations that we had as part of an initiative that we've been working on for the past 2 years, again based on some work that the IHI have done. It's a project which focuses on what matters to our frontline staff. So here are some of the extracts some voices, your tissue warning from just after that first wave.
All you needed to do was look at someone taking their mask off, seeing tears rolling down their cheeks, knowing people were going home and crying.
All you needed to do was see one person come out destroyed. I mean, people at the end of their shift, they're just destroyed, dehydrated, emotional, hot, sweaty, stinking.
It's weird. You've got all the PPE on, so you kind of feel like you're in your own head. You've got this big bubble around you, and it felt like you were almost disconnected from reality or what was going on and your patients.
You talk things through with your family or partner, and it helps you cope with it. But it was nearly at that point where you didn't want to bring that home and then increase their anxiety.
You'd go home. It was all over the news, all over social media, and I found it quite hard. It was never not an element in my life.
Realistically, you're lucky if you get 7 hours sleep and then you're back on again.
When I look back, I think there were times when I was really close to burning out.
I think especially in our role, time looking after someone else, you sometimes sort of forget about yourself.
Literally in a bubble, but feeling this massive disconnect from people around you, and they're talking and things are muffled, but it's almost like you're in a dreamscape.
It wasn't just the workload, it was the physical challenge of the PPE, which you did get used to, but initially it's just like it's so hot and just not being able to drink and just little things like going to the toilet whenever you need to.
I was just so exhausted. And then the next day I was thinking, oh, I've got to go back to work again.
I had a lot of anxiety about, if the patient arrested and I would be in there on my own for like quite a significant period of time before anyone could come and help.
Wearing the PPE I found hard. I found it really hot, and I don't know, just really overwhelming at times. And obviously you would have in the back of your mind that there are PPE shortages, so I would wait until I was really flagging to say, can I go on a break?
In the height of it, I just like completely switched off, nearly to the point where like I was trying to then create myself a little bubble so that I didn't want to talk, I didn't want to go out.
I just didn't know what was going on with me, and I'd just wake up crying.
You physically had to be there while you're listening to the last words, and that really, I don't think I've ever cried so much.
It was evident from these conversations that we had entered the disillusionment and exhaustion phase a long time before we even faced the second wave. Personally, I was absolutely exhausted and couldn't allow myself to even think about having to go again. And then what happened next came totally out of the blue and had nothing to do with COVID-19. We lost a colleague, a friend, a huge character from within our team, the kindest, most caring person that I have ever met, and someone who had the whole life ahead of them. Some of you may have experienced this. It was, in fact, the third time that we have had to nurse one of our own. And it had a massive, distressing effect on us as a team. Next slide, please. So after this, how were we ever going to mount the energy and the determination and the strength to go again? As you can see from some of the comments in the speech bubbles here, we were all feeling exactly the same. There was no real build-up, no anticipatory anxiety about the second wave. Perhaps that's because we never really stopped. ICU continued on full throttle as we went back to business as usual, catching up on all those surgeries that had been cancelled earlier on in the year. Next slide, please, Richard. Much of what I have experienced is described in this document that the British Psychological Society wrote in their guidance for caring for healthcare professionals during a pandemic. So I talk about the anticipatory anxiety, and then that heroics and surge phase where we talked about camaraderie and the sense of rising to a challenge. And then I think my colleagues in their audio recordings there beautifully demonstrated disillusionment and exhaustion. So here I am now. And as of last week, I feel like we've slightly turned a corner and are possibly entering that recovery phase now. But where do we start? I think a major shortcoming in the literature, and one that is probably still prevalent in the current media narrative, is the use of a trauma model to try and understand the impact of high intensity working. Now, I'm familiar with trauma models. We've used them in ICU for some time, and certainly we were using them prior to COVID-19. And they sort of were used after a traumatic event, either for individuals or for the team as a whole. But speaking for myself, this is not what that feels like. And the idea that half of the frontline staff have post-traumatic stress kind of makes me switch off slightly, as if we're all ill and need some form of treatment to be able to recover from this. I feel exhausted at every single level, but this is different because this isn't and hasn't been a one-off incident. I know I'm repeating myself, but I am absolutely shattered. And I need, and my team need, time to recover. And my instinct suggests that we need time off. We need to be able to rest. We need to be able to relax. And we need to be able to recuperate from this. And that's probably just a starting point. I worry terribly that we'll never ever get that opportunity. And evidence suggests that actually the impact of extreme situations such as these on teams points to a fallout afterwards in terms of ill health and staff retention. So knowing that this is not just a possibility, but more likely to be a probability, we've set out in search of the best way of recuperating as a team. Things that we can do actively together to steer us through this next phase. And I guess we're particularly receptive to the idea that the solutions are between us, within our group, that our resilience in recuperation will derive from how we are with one another, which I guess is where Richard comes in and where peer support plays a rather large role. Over to you.
Well, thank you, Mo. What I want to do now is just slow all that down a bit and put some understanding over the important things that Mo has said, and just try and pull out some of the features that really matter. So we're going to talk about primary and secondary stresses. And I'm not sure how much you're aware of this terminology, but it's really quite important. Primary stresses are the things that people get fixated on. They're the things that actually cause the circumstances you're in. So in this pandemic, the primary stresses were, am I going to become sick? Am I going to transmit the sickness to my family or to my friends and colleagues? But there's so much more, as you probably heard in what Mo said, than just those things. And here is something that, that I wrote with Neil Greenberg in a book some 7 years ago, that you've got to be careful of not ascribing to things like SARS-CoV-2 the utter and total responsibility for things. Now, you heard Mo talk about moral injury. What are we talking about here? These are terms, moral injury and moral distress, that actually have come alive during this pandemic. The term moral injury is borrowed from the American military, and moral distress has been talked about by nurses for a very long time, for hundreds of years, in fact. It's all about people aspire to do their best for their patients and how they feel when they can't, for whatever reason, deliver the quality of care that they would like to give and that they have been trained to deliver. I think there have been myriad situations like this during the pandemic where that has taken root. But we know that there can be after effects of having to make triage decisions that can remain hidden for years. People feel guilty. The importance of these concepts is that they are not necessarily pathologizing. So I really rather like non-pathologizing statements, because for the very same reason that Mo said, that I'm not sure that I get a great deal out of diagnosing psychiatric syndromes. And that takes us, if we've got primary stresses, to the inevitability of there being secondary stresses. They are entities in themselves. They include infrastructure failure, challenges to professional practice, and many of these we can see starting well before the pandemic, becoming a huge influence during the pandemic, and they will go on being huge influences when the pandemic is done, if that glad day happens. So what sort of things are we talking about? Well, we're talking about, can you get a hot meal if you're on nights? Can you get a break where you can get a decent cup of coffee? Are there showers that you can get all the grot off you before you go home? These don't sound like very important things, but my goodness, they're vital. They have a huge lot to do. And when you heard those nurses talking, they were talking about how do you cope with the rigors. It's not just whether you've got the PPE, it's how do you cope with it. And so undoubtedly, we've seen a lot of people have been distressed. Somehow, in the course of this, it almost feels to me as if the primary stressor has kind of faded a bit into the background, and we won't know about that till it's gone, really. But the secondary stressors are marching towards us. It's very interesting to hear nurse managers and senior doctors talking about their experiences. What we've seen in the second wave is that these experiences being taken on by them too. The people say to me, the second wave wasn't like the first, and we're coming round to looking at why that might be. Is it simply because people have been through this once already, and how do you get yourself geared up to do the same harrowing thing again? Yes, of course, that's important, but it's not just that. So let's come in and look at social support, the mobilisation and deterioration paths. You see, one of the things I've got involved with in the last 15, 20 years is summarised by this slide. This is a meta-analysis, 148 studies, 309,000 participants in total. It's all sorts of groups. It's professional groups, it's the public, it's all sorts. They were asked to rate the things along the top as having the most influence on their quality and duration of life. Those are the red dots. The green dots are the empirical science. and they put in rank order, so the intervals aren't really equal as they look here. But in fact, this is the difference between the true science and the perception. So people think that social support and social integration are pretty well down the list, and they're a lot more important things. In fact, the empirical truth is they are the two most important things in terms of our life and our living. A colleague of mine in Queensland, Australia, did some research with older people showing that when they retired, if they actually made one new good friendship, their duration of life was 5 years longer. So there's something about our social networks, our social integration, and the support we get from people that is critical. And I don't think we've given this sufficient credence. Let's not rush to diagnoses too fast. Let's see what we can do for each other, which I call social support. And there's a definition with the 5 things which are important about it in yellow. It's about social interactions. And people say to me, yeah, will Facebook do? And the answer is probably not. But a group that you're deliberately a member of probably will. So some WhatsApp groups, my family has a WhatsApp group, and I go along and say scurrilous things about my relatives. But we all enjoy it enormously. That kind of group actually is a social interaction. Actual assistance, that assistance can be emotional support, the figurative, it has to be figurative these days, arm round the shoulder, providing people information. There is no volume of information that is enough for relatives of people in some horrid situation. And only third comes the operational things, the actual practical help that we give people. It's much more the social and informational. But this needs to be wrapped up in a web of relationships that people perceive to be loving, caring, and readily available when they want it. And that takes us to a distinction between 2 types of social support. Received social support, that which people actually give you. And perceived social support is a either more complicated topic. It's thinking, I'm a member of this group, this family, this team, and I know for certain that if something goes wrong, they will be there for me. I can rely on them. The army thrives on this. It trains people to use buddies, to go around in pairs. And why do they do that? Because over the years, they've learnt a thing or two about this. They wouldn't be able to put some beautiful words down around it, perhaps. They might, of course. But the importance is that this kind of perceived social support turns on the power of the social embeddedness of people in their networks. We saw this, and here's a book. This is one of the few books I recommend to people. I wonder how many of you have read Rebecca Solnit's book. She's a social activist and social historian from the West Coast of the United States. And she has written this book quite a few years ago now, 2010, a beautiful book about 5 major incidents in the US over the years. And it starts with an analysis of the San Francisco earthquake in 2006, from which she concluded that actually people know what to do in a disaster, and that it's the loss of power that is the problem. That when you let groups function well, the solidarity, altruism, and improvisation appear from within us. They're there all the time, actually. But it's these kind of tragic situations that bring them out. Hence her title, The Paradise Entered Through Hell. Is that the kind of paradise that Mo is talking about? I don't think I'd want to patronize her with that because she's not out of it quite yet. But let me just hang on to those words. In the first phase of the pandemic, isn't this what we saw? Of people coming to hospitals with gifts of food and all sorts of things, people clapping on a Thursday night that always left me with a slightly uggy feel, because I felt that it could go horribly wrong, but and that blame might be just round the corner. But maybe that's just me as a kind of untrusting person. But that was certainly evident. And Mo said that she felt that some of this was running out before the first wave ended. Okay. But in order to cope, the theory that I'm advancing is that everybody needs to be and feel supported. There needs to be social cohesion, there needs to be cooperation, and people need a sense of belonging to a valued social group or community. And that's what Bill Clinton said some years ago. And he was basically critiquing politicians and saying that they like the conflict, but it's not necessarily what works. And he was reminding us that cooperation is really what it is. And I noticed a huge amount of that. I've been a wonderful spectator of all that's going on as somebody who is a bit older than the average, and with some background health conditions. I've not been allowed anywhere near the hospitals. And Mo said to me, I'm not having you in my unit. So, and I haven't actually gone there yet. But so we were looking at what Chris Caniasti would call the mobilizing support phase. Altruistic communities with groups acting together, a democracy of stress. You could distress, you could share it. Everybody had it. Heightened solidarity, increased social identification. Mo said, you know, I was really proud of my team. That's social identification on steroids. It's reduced levels of cross and inter-community conflicts. Now, I've been part of a group and we've talked about this over the years, for the last 10 years or more. And we didn't know how long this lasted, because most major incidents don't go on long enough for us to find out. Now, there is one disaster paradigm in which you can do this, and that's flooding, because it goes on a heck of a long time. So we dispatched a PhD student to York when they had the last very big flood there, and he went back there 3 times over 2 years and looked at groups of people. And we came to the view that spontaneously this social support phase lasts about 3, possibly 6 months. And there are things you can do to keep it going, but eventually it peters out. So it was with the pandemic, in my opinion. But then we got to about June, July, and things weren't quite so rosy. That's what I observed. I think that's what Mo's told you. And people were getting crabby with each other. The conflict had gone up. And then I found this from a very well-known emergency medicine consultant. I won't say who it is, on Twitter. She records talking to colleagues about feeling disheartened and fatigued. Mo's acknowledged this. And she, I think, gave 5 pieces of quite good advice, I think. It's all a bit shit. If we can acknowledge that, then that means we can disconnect ourselves a little bit from it. Focus on what you can control. Remember, it's this sense of being in control of yourself, which is actually critical to our survival. That's what Rebecca Solnit told us. It's about power. Don't expect too much. Got to be a bit kind to yourself. And don't feel ashamed for feeling badly. And try to maintain compassion and kindness to others. But you can't do the 5th one if you don't do the 3rd one. Okay, here's a research piece of research that appeared. This was where they collected the data on the public in July, and it's very clear that the infighting had broken out by then. So this was not just something in the professions, this is something in the general public, that these bonds were pulling apart. And this is what we call the deterioration phase. And I've spelt camaraderie in a way I don't really like. It is the American spelling. Altruism, camaraderie slowly reduced to be replaced by disillusionment. Isn't that what Mo said? and the harsh realities become plain, and that causes a deterioration in our identification with other people and our support. Why? And there's a list of reasons on that slide. So while the mobilisation of support may turn on actual support, the power under it comes from being a member of a group, or several groups in most of our cases. But the power behind the deterioration lies with this perceived social support. We start expecting, we don't quite so confident in that our colleagues will be there for us. We don't feel quite so embedded in the teams. So what on earth did we do? And I remember having conversations with NHS England about this and saying, we need to get to work on trying to work back towards some cohesion in teams. And we need to do this from the bottom up. Sending experts in isn't what this is about. This is about distress. So how do we distinguish distress from mental disorders? I think that's quite key, quite important. And here's a single slide which shows you what I've learned over the years about how disasters strike people. Now, almost everybody's stressed, distressed. And there are immediate and short-term reactions, and about 50% of people recover spontaneously. They are distressed, but with the support of colleagues, family, professional colleagues, etc., that tends to dissipate. But it may persist into the medium term, and people may develop acute stress. And I'm not going to say too much about that. But I'm very, very vexed about this persistent distress, because we've researched a group of people in Greater Manchester who went through the arena bombing. They went through it, but they weren't injured by it. And we've now showing just how distressed they are after 2 and 3 years. So what we thought was transient distress, well, there's no question marks over it. And then there's grief. And that's all before you arrive at mental health conditions. And there's a list of those which are the most common. I don't know why, but people don't put substance misuse at the top, but it is. So I focused, and I've focused the last 15, 20 years of what I strangely call my career on 1A and B, because I think that that's where the traction needs to be. And I was talking to somebody in NHSE this afternoon about this, and they now get it. They now understand it. And if the pandemic has done just one thing for us, it's put distress and just how important a circumstance it is on the map. I've gone through years of people endeavouring to ignore it. What do people experience when they are distressed? It's these kinds of things. Emotional, cognitive, social, and physical. What we've shown in Manchester is the more physical reactions you have, probably the more serious your problems are. And the social withdrawal is very common, but you will infer from what I've been saying that that's something that has to be challenged. We need to draw people back in to being part of us. So this is what a sociologist would do when they were distinguishing distress from disorder. It's a bit trite, a bit straightforward, but it has some advantages. That it's referable to a stressor. Well, we've got plenty of stressors, primary or secondary, in this pandemic. That it should be proportionate. And I don't know, but it's very difficult, particularly to estimate the impact of the secondary stressors. We kind of get to live with them. We kind of get to expect that the hospital doesn't look after us as well as we would like, etc. We tend to get used to the ambulance service rotating us on shifts that we prefer not to be on, etc., etc. Okay, these are all stressors. But when you get into a severe disorder, disproportionality becomes part of what goes on, and you can take the stressor away, but the problems may continue. Here's some indicators of acute stress reactions. This is like taking distress and heating it up. If you just put it over a cooker, these are the kind of things. And some of them start to look about like the hinterland of PTSD. What do we know about staff? These are the things that make the situation worse for healthcare staff. It's about colleagues and the extremes of life, people who depend on you, in other words. And somatic complaints to primary care are common. The French showed that after the Bataclan events, the events in Nice, and it seemed to weigh particularly hard on police officers. So what happens to people who experience these things? As I said, I described resilient responses, and 50 to 60% of people cope reasonably well. They may be distressed, but with the support of families and colleagues, they get through. And then there's a huge group of people who take longer to recover. And these are usually people where the impact of secondary stresses has been substantial. And then there are people who go into a prolonged stress phase, about 10%, or the people who have high stress throughout. These latter two groups are much more likely to develop syndromes. So let's talk about caring for staff rather quickly. This is the meat of what we need to talk about. I think, again, being pragmatic, let's not get into, is this a mental illness or not? Let's just think about this pragmatically. And here's a nice stuff. This was done for Mrs. May, a report on thriving at work. And Stevenson and Farmer, that's Paul Farmer, who's the chief executive of Mind, drew up this kind of picture, pointing out that most of us thrive at work. And that's where the well-being agenda sits, is how do you keep people thriving? Then there are a smaller group, but a not small group, of people who are struggling in work. They're distressed or they're struggling about other things. And we need to get them back towards thriving, and certainly not down to the yellow group of people who are ill. So that, to me, frames three practical tasks. How do we maintain or improve the well-being of people who are thriving? This is interventions that, or not so much interventions, but these are about the conditions in which we work that ought to be available to everybody. And then we need to provide more focused care for people who are distressed or struggling. And then we need to provide timely access for some people to a mental health treatment facility. Put it another way, support for all employees, targeted support for those who are struggling, and tailored support for people who are ill. This is my diagram, and I call that first agenda, the well-being agenda, something to do with developing workforces, developing workplaces so they're fit for heroes, and providing informal support. We do that for each other every day, I hope. And by the time we get to struggling, then we need to bring on the psychosocial agenda, psychosocial care, and we're going to single out, for a few comments before we finish, peer support. It's only then that we start to think about progressing towards the mental health agenda. So what is it we're going to do? Well, first off is early intervention, that things that work after mass trauma consist of general support and bolstering of the recovery environment. So that means two things, I think, in healthcare. It means making sure that people are members of supportive work groups and actually looking at what the environment at work can do to make things better. That we should base our intervention on the acronym PIES, created in 1915, this acronym by the French in the middle of the First World War, providing interventions for stressed people in proximity to where they are, immediately with an expectancy that they'll improve, and it's the simple things that work. And we need to let you reflect on some of those things, but I just want to pick out the yellow one in item 3, is helping people to restore their sense of agency and the perceptions of themselves as effective people. That is critical to people's recovery. Okay, and the list under 4 says peer support. We are coming back to that. And I use the principles of psychological first aid as some of the reminders of what it is we're doing: comforting and reflective listening, social support for people who are directly affected and their families. Don't forget families. Reduce the effects of primary stressors, assess people's needs, help people to feel in control, adequate welfare, social and healthcare responses to reduce the effect of secondary stressors, and prioritize people who have problems. Now, here's a list of potential actions I drew up for the Faculty of Pre-Hospital and Emergency Medicine in the Royal College of Surgeons of Edinburgh. I just, again, want to pick out the yellow one. It's about trialing mental health training for professional and general managers. This is some work done with workforce mental health training. Well, it wasn't really mental health training, in fire and rescue services, where they trained managers to actually understand how to have a conversation with their staff that would be helpful. And it was randomized. And what we know from the outcome is, in terms of reduced sick leave, for every £1 you spent on the training, you got £10 back in not having to hire agency staff. So for the bean counters, this is magic. Peer support, let's come round to that now. It's about providing emotional and social support for others who share a common work experience. What that means is you sit down with somebody who knows your job because they do it too. So you don't have to explain what it is you do, and for the person hopefully listening to you to get it wrong, because your colleagues like to get it right, because they've been there too. It's about positive outcomes. It's about empathy and equality. It's about, and which is why the shared work experience is so important. It's about dignity, respect, and inclusion. And that takes us to integrity, authenticity, and trust. It's these kind of things that kind of rebuild people's embeddedness in teams and help people to reignite their perceived social support. It's got to be voluntary. So this is what we have been doing. I've been sitting in my office doing these kind of training schemes, and we've done quite a lot of them now, where we've trained teams of people to be peer supporters. And I'm going to invite Mo just to say a few words about that before we close. So peer support, we've discovered, is potentially very powerful, and it can be strung out in all sorts of ways, but we've kind of trained groups of people to sit down with each other and to talk one-to-one about what is troubling them. And in most cases, it's a miracle about how people suddenly feel understood and their problems begin to reduce. Occasionally, people turn up and their problems are clearly rather more severe. And so arranging them for them to be signposted to somebody else who can produce a greater intensity of care is a good outcome. It's not a bad outcome. It's a good outcome. Before all this started, I produced a leaflet, or I inspired a leaflet to be produced, which was called the Top 10 Messages for Supporting Healthcare Staff During the Pandemic. and it's a 6-page document, and it goes through what are the risks and all those kind of things and offers advice. But it starts with this notion of being kind to yourself and one another, about assisting staff to identify and manage their concerns, encouraging them to sustain their social connections, anticipating moral distress and being ready to deal with it. It's about remembering to eat, drink and rest. And you heard from those nurses, did you not? Just how difficult that is. It hadn't gone off their minds. It's just that they were so responsible about not having to discard PPE unnecessarily when it was short in supply, that they actually, that they put themselves last. It's about continuing supervision and training during a crisis. And it's dealing with the incipient loneliness. I think we heard some of that in Mo's clips of people feeling in a bubble on their own. And that means that support and leadership for staff should be visible, that senior staff should be shown and show themselves to share the risks. It's about following advice and being aware of guidance. So those were the simplistic things that we came up with. All this is about getting the moral architecture of your workplace right. And this was the subject of my inaugural lecture back in 2000. When I talked about this, it was peppered with Blackadder clips, because that was the thing of the time, when Baldrick had a cunning plan, if you remember. They didn't always work, Baldrick's plans, but we're going to talk to you about a plan which does work. And it's about saying that if the organisation is moral, then it will look after its staff in the way in which it would like its staff to look after the patients. So let me just remind you, as I come to a close, that it's a triad of things that's really important. It's about leadership. It's about social support, including for staff peer support. And it's about ensuring that we have cohesive teams. Let me stop there and let me invite Mo just to reflect for a moment or two before we go to the questions about her reflections on peer support.
Thank you. So we met with Richard for the first time last year when he very kindly offered us training in peer support. And we actually, we did our training with Richard literally weeks before our colleague Jack actually died. And it was interesting, immediately in the days that followed after Jack's death, that the trust planted various psychologists on the unit to come and support us, and yet very, very few, if any, of the nurses actually took them up on this opportunity to talk, offload, share. And I think it was probably because none of us really wanted to, and all we really wanted to do was talk to one another, because we all knew and understood what each other were going through. And that's really where peer support took off for us. And I think we have been notoriously bad over the years of talking and sharing, and certainly within ICU, I think our mentality up until recently has been that we're hardcore, we don't need to worry about things like this. But actually, if anything, this pandemic has taught us is that actually we do need to talk, we do need to offload, and it just makes sense to do it to people that have that shared and common ground, I guess. And it seems incredibly natural approach in supporting one another. We have already started various peer support sessions on the unit in the last week or so, checking in with everyone to see how they're sort of doing following on from this latest wave. It's actually been really interesting. We've learned a lot from it, and actually we're not as broken as we thought we were, which was really incredibly reassuring. And just having that period of time to talk to one another and support each other, and if needs be, signpost each other to other areas of support has been invaluable. And yeah, I think everybody should do it.
Okay, thank you very much. So, Andrew, back to you.
Excellent. Thank you very much, Professor Williams, and thank you very much, Mo. Absolutely strung very close to my home listening to that presentation. And I'm sure I can see from lots of comments that it also resonated with lots of people online tonight. Let me just share my screen because we've got some fabulous questions that I want to ask you, really. Some of the questions I was thinking, and as I was thinking, somebody actually typed it. And so let's jump over to the Q&A. Everywhere has asked, I work in theatres, and my worry is that we are being told we're going back to normal to provide services to patients. Whilst we're happy about this, we also need to time to recover. How do we balance the need of this service and the need for us as individuals?
Well, this is a conversation that I've been having with NHS England at the highest levels. I think that worries me, that if people don't get some downtime, that they're going to carry the strain with them. And I think that we need to make it possible for people to have the time out, and that we may have to slow down the return to ordinary practice. I think one of the problems in the summer of last year was our rush back to recover the service, but not recover the staff. And I think that that was reflected, I think, partially in the uphill struggle in the second wave. So I'm concerned about this. I don't know that I've got any trite answer to it, but I'm certainly pushing at this, as my colleagues are, at a national level.
Excellent. Thank you, Richard. Effa, thank you very much for that question. And again, thank you for joining us again. Question from Jenny. What are your opinions surrounding the idea of post-traumatic growth? Do you feel this is something we will see affecting staff in the coming months and years?
Oh, I certainly hope so. No, I believe in that as a concept. And I've just been reviewing some papers that we're publishing, not my papers, this is papers about families, showing that in the lockdown, actually, despite all the hazards that we've been talking about, and which are talked about every night on the television, in the social media and everything else, there has been quite a lot of growth, that parents have got closer to their children than perhaps they might have done. Certainly my families, I've got 3 children, and they all have families of their own. And actually, I think they've got quite a lot out of it. At least I think the kids have. Maybe the adults have got less, because they felt strung between the parenting bit, the homeschooling bit, and their own jobs. But what is clear, and this is the bit that worries me, is it's much easier for well-to-do people who are affluent and have financial resources to be able to do this, are much, much more difficult. And that's my real worry, is that growth may be much tougher for people who've been through some of the worst of this. I think something like 90% in this particular paper of families had some degree of post-traumatic growth. But it's not all families that have the resources, and we have to think about social equality in all of this. And it's not very far around the corner from some of the politics of social deprivation, I fear. So yes, I think that's entirely possible.
Excellent. Thank you, Richard. We have another question from Deirdre. If all staff are affected by the pandemic stress, are any of them actually still able to give peer support? We have managers and mental health first aiders, but it seems that we are trying to tap a resource that is already tapped out.
Yeah.
Mo, do you want to come in on this one?
Yeah, it's interesting, isn't it? In fact, I've had a few of my own team that have not accessed peer support because they're worried that we're all absolutely overwhelmed and exhausted ourselves. But I think I'm very fortunate in that I personally hold a management role for wellbeing within my ITU. So I will do 1 day a week that's just dedicated to to wellbeing. And so that protected time does allow for me to be able to offer peer support training. I appreciate that that doesn't happen in many other places. I think it's really important to remember when you do offer peer support, that you have to make sure that you are in the right headspace. Otherwise, you're not really of much use to anybody. So it is tricky at the moment. It's a real balancing act, really. You just have to be incredibly honest to your colleagues if you are peer supporters and you don't feel like you can offer at the time because you're not in the right place. But the fact that you've heard them and said that you will absolutely do something about it, I think is really important. But yeah, it's tricky at this moment in time to be able to offer a comprehensive service. But yeah, I'm fortunate where I work that I can.
Excellent. Thank you very much, Mo. Fab question, Deirdre. Thank you. We have another question here for you, Mo. As an ED nurse, this has been an exhausting time for us all. How have you been able to take time out of such a busy ITU environment as a team? Staff sickness has been seen most of us working overtime to cope with day-to-day running of the ED.
So we haven't taken time out. I don't think anybody has, and I think like you guys, we've also worked extra shifts, still doing bank to cover the acuity more than anything. I don't know that our sickness is terrible at the moment. I worry that it could get worse, but yeah, we haven't had the opportunity to take time out as such. I think we're actually looking at the moment in ways that we can almost sort of change so other jobs that we can do with an ITU, so that you have sort of like a change of scenery, because sometimes a change is as good as a bit of time out. So we're sort of looking at other roles that we could be taking on that might not be so intense at times. But no, we haven't been able to take time out as such. All we're managing to do is sort of take 10 minutes with each member of staff, sort of to check in with them, really. But time out is, I think, a luxury that we don't have.
Excellent, thank you, Mo. Just a couple more questions. How do institutions, departments access the peer support training?
Well, they do and they don't. The Intensive Care Society has set up training. We were involved in training a dozen or more trainers for them. So it's being rolled out to ICUs. And we're kind of experimenting with taking this into emergency departments. So we've been asked by the Welsh Government to do some work on that. So it's beginning. I think there's no easy answer to this, because there are more people wanting to do this and to be trained in it than we could possibly train at this point. What I'm keen to do is to get it taken up. And I was talking to a critical care consultant this afternoon from Mo's unit, who sees the importance of facilities in hospitals making this part of their ordinary routine. And therefore, it seems to me that a small number of training courses could go a long way if it was possibly properly organised. We prefer to train teams who work together because they know where they're coming from, and it actually is part of the binding process, rather than training single people who go back and try and sell this to their colleagues. I think that's a much tougher ask. But so we always set some stringent conditions on units that want to do this. But I'm hoping that over the years that I have remaining to me, we can go on and try and run this out as fast as we can. But the real answer is that hospitals must take this up and learn it for themselves, so they don't depend on external trainers.
Excellent, thank you, Richard. Just a couple more quick questions. Steph has asked, is there any guidance for timing for peer support, as I felt I needed a period of silence recovery before I wanted to talk?
I don't know if Richard's going to say. What I was going to say is, because peer support is a self-referral, if you like, process, there's no sort of timing as such. It's just when that person is ready and wants to access the support service that we offer. So there's no actual sort of timing as to when to ask for help. It's not like other trauma programs that are out there where they sort of dictate, or not dictate, but suggest timeframes. I wouldn't have said this does.
We try and make this as non-institutional. We don't see that accessing peer support from your colleagues is a referral. We don't see it as necessarily generating a record. Yes, we need to keep some sort of record so that things stay on track, but most units have evolved a mechanism of keeping the briefest of records and then agreeing to get rid of them after about 6 months. So this isn't a referral like a hospital referral. My wife's just been referred to a dermatologist and you get a formal letter. Nothing like that is going to happen. That's not how we see this. So I think people come when they're ready to come. And indeed, it would undo it if people felt they had to do it. I don't think that's in any way sensible. It has to be voluntary.
Excellent, thank you, Richard. Gavin's just made a relevant comment. If you can be of any support as a pre-hospital worker to anyone, even if it's a meet up for a coffee and you want to unload or have a chat and get that weight off your shoulder, then just talk to each other, because on average, I know as being a clinician, we'll often see broken members of staff quite easily and we'll spot them, but because everybody's so busy, maybe it's just not as transparent as it would normally be, Gavin. So maybe it is about looking out for each other and trying to look for them telltale signs that actually somebody just needs that extra support. Last question we have from Maldwin, which is a good question, and I'm going to point this at both Mo and Richard. Who supports the peer supporters?
Very good question. Brilliant question. I insist that before we teach this, that we have an arrangement worked out with the client units that we go to do this. And so far we've been going to them online. The original idea was to teach this over 2 days face to face. So we had to turn right round when the pandemic started and transfer this into a course delivered over Zoom. And we managed to get it down to the inside of the day and it works well. But a condition is that we won't teach it to units unless there is support for the supporters. So we are very keen that they find a suitable mental health professional and that's the only contribution the mental health professionals have to this, who know the unit and can offer supervision sessions to peer supporters, not in a sense of in-depth supervision, but certainly being there to provide that kind of contextual support for people who are doing something that just could turn out to be a bit demanding. So yeah, we are very keen, and we have these discussions in the preparation phase before delivering training about making sure that those arrangements are in hand and will work.